I'm going to introduce our speaker for today, who is Jennifer Novak. She is the owner of Peak Performance Strategies in Atlanta, Georgia. For those of you on Facebook, you know she is probably one of our most active posters out there, and she has a wealth of knowledge. And as a result of that, we thought it would be great to invite her, and we're very thankful that she was willing to come and speak. So Jennifer, I'll turn it over to you.
In my pocket. Hi, it's really good to be here today. Thanks for coming in to listen to me. I have 30 minutes. That gives me enough time to probably just pique your interest and maybe give you some appreciation for how I've been able to utilize isometrics in performance recovery. And without further ado, since all I have is 30 minutes, why isometrics? This is a pretty famous picture of LeBron James doing a mid-range shoulder flexion isometric, full elbow extension. This is his "what were you thinking" isometric that he did during the NBA Finals. And it doesn't matter anyway because it's at the Lakers. So I've renamed isometric exercises for the basis of the reasons that I use it. I call them PVMC exercises, which stands for Positional Volitional Motor Control. It's not a very sexy name, but it gets the job done. So why do I call it that? Number one, you're involving active client participation. You're creating an attractor state. If anybody in here a fan of dynamical systems theory of motor control, you're creating an attractor state and you're improving body mapping, spatial awareness, where that part of the body is in space. You're providing an external focus of attention, and in research that's shown to enhance your response times, your coordination of movement, and even your motor learning. You're going to activate multiple brain areas. I have a special slide just for that. And you're going to be able to make both peripheral and central changes utilizing PVMC exercises. Here's the multiple brain areas. This is a unilateral single joint isometric. You're going to get areas involved with motor output. If you want the special name, it's in parentheses. Complex movement planning, planning and execution. How about a reward system? Motor tone, movement coordination and execution, and even the processing of sensory input. You get all of that with a single joint unilateral isometric. And if you want to add multiple joints, you're going to get the premotor cortex, which is involved in multiple joint, more complex movements, and also the somatosensory association cortex, which deals with body mapping and that complex spatial awareness. Ta-da! That's actually my Facebook profile picture right there. Passive movement. In my world, that would include things like stretching, maybe foam rolling something, if you got a deep tissue massage. You're hitting one area of the brain, and that is the somatosensory cortex. So the body knows, the brain knows that something is happening, but how do you bridge that gap to make it talk to the other brain areas in terms of learning a skill, relearning a skill, or improving performance? Why wouldn't you insert a targeted PVMC exercise here? You have to ask yourself, is that body dynamic ready? Who knows what regional interdependence is? Everybody, right? Yeah. So a muscle does not have to cross a joint to affect motion and function at that joint. And I see that in evidence every day of my practice. Does this system need some kind of input that precedes that dynamic loaded movement as preparation for that movement, especially after an injury or setback? I would say yes. You can utilize PVMCs to be prehabilitative, maybe to make somebody less vulnerable to injury. They can be rehabilitative, and I am actually going to loosely show you some studies that talk about the different stages of tissue healing and where you might insert one of these to evoke a positive change. And you can use it in post-rehab, which is really where I am, where I support strength coaches in helping them get their athletes to optimize training response after an injury or setback. So it's kind of like they're in that little bubble between rehab and performance. So I call it a strategically designed bridge between sensory input and association and the planning, coordination, and execution of sport movement, but also the training for sport movement. First of all, you've got safety and versatility involved in your PVMC exercises. They're adaptable to your pain-free joint range of motion. You can adapt them to any joint angle. You can even estimate force tolerance in that muscle or in that position by if they push too hard into that movement, you're going to have pain, so you back off the pain, right? You have all these variables that you can inject in designing. This is why I called it a lost art. It is an art to design really quality isometrics that can bring that athlete out and call those muscles and those positions back online so that they can work better. And you can use them relatively early in the healing process all the way through to return to play. So here's my first study. I'm going to run through these really quick. Put on your seatbelt, please. You can use them as an analgesic agent. This particular study was an in-season basketball and volleyball, both males and females. They all had patellar tendinopathy, and they did extension leg holds. 80% of their maximum, 4 times a week for 4 weeks, and they had both acute and chronic changes in pain sensitivity. I've fallen and I can't miss my game. So I'm just going to give you one example of where I put this research into practice. I got a phone call one time from some athletes that I worked with. They were out of town. It was a collegiate basketball player. He was running through some plays the day before a game and did a little roll of his ankle. It wasn't severe, wasn't a whole lot of swelling, but he hurt. So the strength coach called me and he said, look, is there something we can do? And we talked through what the range of motion deficits were. And I instructed him on how to do some low-level isometrics for his ankle. And I got a text in about an hour and a half saying, hey, his pain went down to like a 4. I said, great, let's do those exercises about 2 or 3 more times before he hits the game tomorrow. And sure enough, they repeated those, and he was able to play the game with no problem. How about improved lymphatic flow? This study was done on men. Half of them were endurance trained. That's only important for one of the results. And they used a radioactive isotope to measure lymphatic clearance in the vastus lateralis muscle, post-isometric, post-PVMC exercises. And they were doing knee extension isos here again, but they used 2 different joint angles and compared it to dynamic exercise. So they found that these PVMC exercises increased lymphatic flow 3 to 6-fold. The interesting thing was that they did both 90 degrees of hip flexion and full extension to do their isometrics, and it was the full extension ones who were closer to the 6-fold here. So obviously either muscle contraction rate, maybe a number of motor units, or the joint position, something had to do with that lymphatic clearance rate rising up. The puffy knee replacement problem. This gentleman was a 60-year-old, he was actually an executive, but he was retired from collegiate basketball, and he injured his ACL when he was in college and never got it repaired. So at age 60, he needed a knee replacement. Surprise, surprise. By the time he came to see me, he was about 7 months out from that surgery, complaining, though, that even after physical therapy, he still felt weak in his knee, like it would buckle out from under him. And when we compared that knee to the other side, it was just very, very swollen still. So we established a pattern of isometrics for him, utilizing every muscle that would cross the knee joint. And over a really short period of time, not only did the swelling reduce, but he got strength and stability, and he was able to go on with his daily activities. All right, I asked the executive committee, I said, you got to give me one body part if I only have 30 minutes. Where do you want me to talk about? And they said, how about back pain? Very ubiquitous, right? Here's a couple of studies here. Here's men and women, various ages. I think they ranged from 35 to 70, and they all had lateralized low back pain, meaning that obviously it was worse on one side than the other. And they compared isometric trunk exercise to global dynamic trunk exercise. And I'm assuming by that they meant the Supermans and the bird dogs and the whatever else, whatever other names people call for those trunk exercise. Look at these results though. So in lower back pain, they find that there's a delay in the anticipatory postural adjustment, meaning the reflexive part of your multifidi kind of slows down. 1 session reduced that delay. They found that the whole 3-week intervention was superior at encouraging neuroplasticity, changes up here, than the dynamic, and it also decreased cortical excitability, which in chronic low back pain people, that tends to be pretty high. Here's a couple more. 52 male and female patients who all had disc herniations with sciatica. You work with people who get sciatica? Yeah, me too. They started really early with these interventions, and they did supine and prone PVMCs. They improved pain scales, they improved strength, and they improved active straight leg raise performance. There's a second study done on young men who all had low back pain. This is a 6-week intervention. Look at this time. It's barely any time at all. 5 sets, 5 seconds on, 5 seconds rest, 3 times a week. That's not a lot of time to dedicate to improving back pain. They improved EMG activity and decreased the pain scores. Pretty cool. All right. When I'm designing by artful PVMCs, you have to consider physics. There are axes and moments involved in movement, and it's really important to know and look at and evaluate both sides of a movement axis when you're designing these. This is a really cool story, actually. His glute is kaput. So this is years ago, an NFL player, off-season. He was actually a free agent at the time. He had been released for injuries, and he said, "Hey, my off-season strength coach says that my glutes aren't firing. Can you come look at this?" I said, "Well, yeah, we'll look at it." And took his health history. Turned out that he had an abdominal strain on that same side earlier in the season, and with my evaluations, which are pretty detailed, I discovered that he had what Yonda would call tight, weak hip flexors and adductors on that same side. We created some isometrics, worked him through the program, and then were able to get his glute firing again, for whatever that means when you're not measuring it. But he was able to actually reduce his 40 again and play another year. He was a veteran, and he played another year. So axes and moments. Give me a moment. See what I did there? And I'll give you a targeted PVMC exercise to support the progression of your athlete. So this is going to be one of my tennis athletes. He agreed to be my model. This is him playing 2 years ago in the BB&T Open, but I've been working with him on and off since he was a high school nationally ranked athlete. This exercise is, it's engaging really the entire anterior chain. If you take a look at it, it is based on a study from a Korean university. They found that if you cue somebody, he's kind of he's in a little crunch there. If you know Pilates, it looks like hundreds position. And I'm the one holding his feet into dorsiflexion. And the cueing is to actually pull the navel in at the same time you're drawing into more dorsiflexion. And they found over time that this helped engage the lower transversus muscles better, which of course is a really prime muscle for helping low back pain. If you have a quad dominant athlete and they say, "I'm not feeling this in my abs," give them a ball or a yoga block, something to squeeze between those thighs and take the rec fem out of it, and then they'll start to feel this. My cueing is say, "Hey, do this until you feel the muscles below your belly button activating." And then we hold it, we breathe through it. Here's another sample strategy. I'm calling these supine strategies because I'm going from lying down to seated to standing, because changing a base of support obviously changes the intensity of an exercise. So this is kind of a modified V-sit, but his heels are on the floor, and all we've done is given him, this is unilaterally based. He's got a 10-pound med ball in his hand, and he's keeping that hugged close to his body, and as he leans back, it forces those right trunk muscles to engage to keep him centered. Here's another thought about designing your PVMC. Mechanics, you have to think about joint structure and function. We're talking about the lower back, so here's our SI joint, and I'm just showing that to set up my next exercise and some reasons why I created this. So it kind of looks like a glute ham machine exercise, right? But when we put him on the glute ham machine, he felt his back. So what did I do? I put him on the floor. He has a broader base of support. I have his legs turned out for a reason. If you ever do cadaver studies, you will see that the long head of biceps fem is actually contiguous with the sacrotuberous ligament. And if you can activate that long head of biceps fem with the glute max on the same side and the opposite side multif, you've got a really nice nutation, counter-nutation force vector that stabilizes that SI joint and will hopefully make this guy less vulnerable to any aberrant shear at the L5-S1 junction. Oh, I had a study. Forgot to mention the study there. I'm moving on, sorry. Another design consideration, kinetics. You need to think about muscle action, muscle synergies. Again, I will say a muscle does not have to cross a joint to affect motion and function at that joint. This particular study, game time T minus 4 hours, what is going on with my hamstring? I do not like passive interventions short times before competition, particularly because I just showed you what brain areas are stimulated. You really want to keep the brain engaged. So this was the top shooting guard for a collegiate team. I was traveling with them for their conference tournament, and we're all getting the pregame meal, and here's their top shooting guard in the corner stretching his hamstring. So the strength coach goes over and says, hey, what's going on here? And then I come over and say, what's going on here? And he was just having a real problem with his hamstring for an unknown reason. So I evaluated trunk motion, hip motion, and leg motion. And I said, I think this is really coming from your trunk. And I gave him trunk isometrics. We sat right there on a table and did it. And his hip extension came back. He stood up. He said, oh my God, my hamstring feels totally different. And he actually scored the winning basket that night for the first game of the tournament. It was pretty exciting. Kinetics, muscle, action, and synergy. Okay, moving on to seated strategies. I call this the stability ball hug. Now it looks like he's using opposite arm and leg to hug that ball, but utilizing the ball as a tactile cue on his trunk, I'm actually instructing him to squeeze it diagonally with his trunk, creating a little bit of flexion and rotation in the trunk and some flexion and hip approximation down below. Let the controversy end. I have made the leg extension machine functional right there. If you've been in the industry any time at all, you know there's been a big controversy over our leg extensions functional. Well, what I've done here is I've actually taken the cam for the legs way out to almost terminal extension, and I've given him a resistance band that I wrap behind the back. So he is moving, this is kind of a later stage, you wouldn't do this with acute back pain. He's moving into hip flexion along with trunk flexion. And I love utilizing this in kind of a ballistic manner, for lack of a better way to put it. But if I can bring him out of that really quick, you've increased firing rate and it stays there. And it actually teaches an athlete how to move up and out of ready stance to maybe chase after a tennis ball in the case of this athlete. Here's another seated strategy. Yes, that's a back extension machine. Yes, I have it pushed all the way back and all the plates loaded on it because I don't want them to move. And that's his serving arm. So if he were to need, he actually had a lot of thoracic extension, but he didn't have a lot of stability in his lumbar spine. But if I needed this, this combines that thoracic extension with rotation and even a little bit of retraction of that scapula for the beginning phase of a tennis serve. Here's a standing strategy. This is pretty simple. He's in ready stance. He's holding a 10-pound med ball that I give to him to hold at his chest. We're biasing to the left side, so he moves it over his left pec, and then I just instruct him to start lifting that close to his body, up toward his nose and even to his forehead, and then when he feels those erector spinae kick in, that's where we hold the isometric. Another sample strategy. Everybody knows the Palloff press, but I probably have at least a dozen variations on this theme, and the only reason I'm showing this one with a ball between his legs is because when we didn't have that ball between his legs, he felt his back. So I just gave him that extra bit of support down the chain close in there. All right, if you don't take anything else from this talk, the isometric mid-thigh pull is my favorite PVMC to give. Why? Because every joint will find its voice. This exercise is known for increasing sprint speed and counter movement jump performance and even tennis serve velocity, yes. And I had to improvise here because I only have one power rack in my gym and it was busy the whole time I was doing this photo shoot, so I used a Cybex machine. But even if you've done some kind of passive intervention here, every joint it can possibly be changed even above and below what you've addressed. So here you have the ankle, the knee, the hip, the sacrum, every joint in the spine, and even the arm is at least reporting something to the brain with that change that you've made. I hope that makes sense to you guys. So now I've got some extras. It's a little study sandwich, I guess. How about using PVMC for damage protection? What do I mean by that? This study done on untrained men, they studied using PVMCs on elbow flexors and seeing if it did anything to prevent extra muscle damage during eccentric contractions. So they did a single set of those, maximal, 2 days before doing maximal eccentric contractions. And they reduced CK levels of domes, and they also attenuated the reductions in peak force that you get when you do heavy eccentric training with prehabilitative PVMCs. I put that little mouse there because there's a separate study, and it was done on mice, but it gives us kind of an inkling as to what the possible mechanism is here. When mice had this done, they actually released neutrophils without any muscle damage, and those are like the first responders. They're going to be the ones that signal the macrophages to come out, and even I think they're starting to say that they're talking to the satellite cells. And so that could be the reason, is that they're kind of setting the stage and already entering you into repair phase before you do those heavy eccentrics. How about increased tendon stiffness? This is super important. How about ACL injury prevention? This study was done in healthy people, but they were studying ACL loading mechanisms and the tibial translation, which we all know is a problem in that area. And they did 6 weeks of a really interesting, they called it an oscillating isometric. So they were pulling with a prone hamstring curl and at the same time giving manual force on the calcaneus, pushing down. That's the unfortunate thing of this study because you can't measure someone's hand pushing. But it was only 45% of their maximum. And they improved muscular tendinous stiffness in the hamstrings and reduced that tibial translation. I think that's pretty cool. Now, a different study I'm not going to discuss here was studying quad tendon stiffness, and they found that longer duration, that's one of my variables, is important for tendon stiffness development. In fact, for that one, they found that the 20-second hold was way better at increasing tendon stiffness than just a 2-second hold. How about IGF-1 and MGF expression? Anybody work with bodybuilders? They love those. Healthy women did one single bout of isometric exercise, and they biopsied their muscles at 2.5 hours and then 50 hours afterward, and they found that they had significant increases in both of those. The IGF-1 at 50 hours and the MGF was at 2.5, but it does indicate that you've got repair and growth factors at work. It's pretty cool. How about this one? This one is a study waiting to happen. Who wants to help me design it? Medicated hypertensive patients had high blood pressure and reduced autonomic function. Does that sound like someone who's overreached or overtrained? It might. 4 2-minute hand grip isometrics. You got a dynamometer in your lab, in your office? 30% of their maximum. This is nothing, right? They improved the systolic and diastolic numbers, improved nonlinear HRV measures, and autonomic function. And then they think that the possible mechanism is that it's training you to kind of toggle between sympathetic and vagal activity, and it kind of helps you recover. So let's design a study. Who's game? Talk to me after class. So yeah, I'm just saying here's a recovery option from overreaching and overtraining. And my last slide. I want you to remember those design considerations and the variables that you can manipulate all over the place depending on the goal that you have. By activating key brain areas, you might provide a missing link between any passive intervention and going back to the training room or onto the field or court. The earlier healing phases These may provide restored motor control, analgesic effects, and improved lymphatic flow. During the later healing phases and back to return to play, you might get protection from excessive eccentric damage, improved tendon stiffness, and improved IGF and MGF expression. And then, of course, my last one, the potential recovery strategy for overreaching or overtraining. I probably created some questions. I hope I did, because all I did was give you an overview. But I've been utilizing this type of work in conjunction with strength coaches for 12 years. It works really well for me. My heart is for athletes, and whenever they come to see me and they've got a problem, I give them everything I've got to make sure that they're getting back on target with their performance goals. So this is my contact information, and I don't know if I stayed on time or not.
Time for questions?
You do? Okay, time for questions.
I'll start.
Awesome.
Can you go back to the low back studies?
I don't have my glasses on. How do I find these? Hang on.
Sorry.
See, it's all, I gotta click on a study because it's gonna divide how do I do it?
Just go.
Just keep going and
Just keep
undo
going.
one at a time? Okay.
It'll be concentric instead of isometric of the finger flexor.
Those
Okay.
those one group or two groups?
It's two different studies.
Right. Was each study, was it one group that just did, or there was a group that did something else?
They had control groups, I believe, in both of them.
They did.
You know what I can do? I'll email you the studies. How's that?
Yeah.
And in fact, within the Facebook group, if someone says, "Hey, can you post that in the Facebook group?" I'll do that.
Other questions for Jennifer?
Yes.
If I understood correctly, on the studies for hypertension,
Yes.
and it was rapid, but I think I got some of it. With the 30% effort, you saw significant increase in, or decrease in hypertension.
Yes.
Is that right?
Yes. And even changes or improvements in HRV,
Okay. So
heart rate variability measures. Yes.
my question is sort of devil's advocate here.
Okay.
With regard to if the patients are only giving 30% effort, would that not encourage them just to give 30% effort rather than to increase their effort and improve their hypertension?
Right. You know, this is the only systematic review that's available on anything concerning isometrics. There's no consensus in the literature. That's why it's an art, and that's why I have to create what I'm doing, because you can't find something that says, if you want to do this, and if you want to do this, do this. But there is a systematic review about the blood pressure one. And that particular study actually was commenting that we found that you could use less intensity and still get the same results than some of the other studies had proven. So hand grip strength, isometric strength, is actually related to a lot of good things like brain health and reduced bone loss and all kinds of things. So I just find it interesting that just about every strength coach has a dynamometer, and could they sit there and say, okay, you overreached today based on, I see somebody back there that does a lot of work with polar stuff, and you could say, hey, your heart rate's kind of high. What about giving them a hand grip exercise and getting them to calm down a little bit? I think it might work. Who else? I expected somebody to ask me, but what about PNF stretching? Because, right, you do an isometric and then you do a stretch. I'm actually, I think, proposing here that you do it the reverse, right? If you do a stretch and you've done something sensory and you've changed that stretch reflex, at least temporarily, why not follow up with a well-designed PVMC to re-engage the brain areas that can actually utilize it? And that's why I like the isometric mid-thigh pulse so much, is because no matter where I've made a change, you've got regional interdependence, you've got muscle synergies, If I throw that isometric mid-thigh pull in, and this is not a max effort, probably 50%, but if I put that in there, then every joint has a voice going to that parietal lobe, right? Every joint gets a voice. That's cool. Yes?
Jen, what about the time under tension? So I see a lot of practitioners use PNF from 1 second, 2 second, 3 second, 5
Right.
second, 6 second hold.
Yeah.
All the way up to 10 seconds.
And the studies show there's really no difference. That's what the research is showing now, that there's really no difference in that length of time. But those short-term ones, that's what's going to change the stretch reflex. Okay, so that's in design, that's in changing your variables. If you want tendon stiffness, you're going to go harder and longer, right? If you want, and you have to judge someone's tolerance. What is their tolerance for force application right now? What is their pain threshold? Where's their pain-free range of motion? What joint angle, are you working with an ACL repair, and when you come into 70 degrees of knee flexion, they're okay, but the minute you go to 60, they're hurting again. Well, you can change this almost infinitely for the person in front of you. I love it. Can you tell? Yes?
Yeah, kind of along that note, with the acute patient that comes in, do you implement the BVMC day one to try and make those neurological sensory changes, or do you implement more passive stretches because there may be fear avoidance?
Yeah, like kinesiophobia. So I'm a post-rehab professional, so I'm not typically seeing an acute patient, but I certainly don't think if it's pain-free for them and it can provide an analgesic effect, I don't see where there would be harm in it. I could be wrong. Someone who has that experience can chime in and say that I'm wrong. I don't mind. But, that analgesia is huge, right? Because it's the pain that causes the fear avoidance. And if you can get them to reduce the pain, and they show that the PVMCs, that I'm liking to call them, they show that it can last up to 45 minutes. So you get a window of opportunity where maybe they don't hurt as bad, and then you can do some things with them, right? Are you a physical therapist?
I'm a chiropractor.
Oh, okay. So, yeah, to me, this relates totally to some AK theories, right?
So,
And functional neurology. Did you do any of that post-grad work?
yeah.
Love it.
And so it's interesting because some patients will walk in unable to walk correctly, stand correctly, whatever the case may be. To get them to do a PVMC off the bat is more of a challenge. So if we can get their range of motion improved passively and then introduce range of motion in that pain-free range of motion,
Right.
that tends to get them better.
Right. So that's what, yeah, that's what I was saying. So instead of doing PNF where you contract and then relax and push it into a stretch, maybe stretch somebody and then do a PVMC to encourage stimulation of those other brain areas. So I work in a chiropractic practice, and I've learned a ton from the chiropractors, but one of the things that she says she's learned from me is to incorporate isometrics with her patients. So, yeah. Yes?
I guess my question is when you're looking at where you're going to do range of motion to initiate these, because you could have a joint that's got fairly decent range, but still has a painful point to it. Do you really try and do your isometrics more at the extreme of the pain-free range, or still in mid-range?
Are you referring to passive or active range?
Active range.
Okay. So I would always look at active range in that case, and I would go just before they start to experience pain. So yes, that's a great question. Or that's what I do anyway. Anyone else? Yeah.
Are there any positions or exercises that you wouldn't hold in isometric?
If it creates pain, I mean, I can't give you a specific one, but if it creates pain, if the person doesn't improve, if you do sets of these, sometimes people will look spongy or shaky, or they'll try to compensate out of it. They'll change, if you're doing an external hip rotation with extension, and they don't like that, they'll start turning their leg back in. So if you see that compensation, you know that that violates their force tolerance, right? And so you just back off. That's why it's an art. That's why you have to design it. And you know, fortunately for me and unfortunately for athletic trainers and strength coaches, they don't have the time to dedicate to athletes one-on-one like that, especially the strength coaches. So, yes.
So, kind of back to where she was at, you said you would hold the isometrics just before the point of pain within the range. Do you also do different points within that pain-free range of motion, or just before the point of pain?
That's an awesome question. So because it usually provides an analgesic effect, and if it doesn't, I'm usually referring out because there might be something going on inside that body that I don't have the power or the credentials to diagnose, right? But what you'll get a lot of times is a carryover. So if you hit right before that pain-free range of motion and do a little set of low-intensity isometrics, have them breathing through it so they're oxygenating the area, right? Then see if they can move into a greater pain-free range, and then you can work from there. It doesn't always happen. It really depends on the body in front of you and how acute they are, or how much inflammation they have in general. That's for a whole different talk. Yes?
How do you determine your percentage of maximum activation?
Oh, that's a great question. Do you know I'm in the process of designing a measuring device? Hopefully that will attach to either the wall or a squat rack where you can do that. It's very hard to do that unless you have a lab somewhere, and I don't have a lab where I am. So I can't follow these exactly, but I think I can give them verbal cues to encourage, you know, when I'm trying to do really light force, I say, you know how you press on a steak to see if it's done when it's on the grill? Press about that hard, right? And then if I'm trying to get a maximal out of somebody, I'm going, come on, pull, 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 or push, 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 do it as hard as you can. Is that as hard as you can? Can you do it any harder? You know, I'd love to have a lab. I'd love for someone to call me up and say, let's do some studies based on this. Anyone? Pick me. I'll help you design it. But it works for me. You know, I'm research-based in my practice, but I'm empirically driven. And this has empirically been working for me for a long time, helping athletes, and I want to continue helping them, and I want to help the people who also do what I do, help them too. So, anybody else?
Well, Jennifer, thank you very much.
Thanks for having me.